Hello, everyone, and welcome to the Accreditation Huddle series. My name is Jimmy Norris, and I'm your facilitator for today's meeting. And Jonathan, you can go to the next slide. So I'm a PATH project manager from Oklahoma. Also along with me today is my co-host and chat monitor, Carmen Alexander. Carmen is a quality improvement advisor from New Mexico. We also have with us today our PATH subject matter experts ready to answer any questions you might have. So for today's huddle, we're going to talk about the Joint Commission National Patient Safety Goals. So as always, please type in your name and facilities in chat. Next slide. So on today's agenda, we will review the objectives and the National Patient Safety Goals. Then we will finish up with an open discussion. So we encourage you to ask any questions or share experiences that you have related to the accreditation or the PCMH certification. Next slide. So these are the previous sessions that we have covered. We are now on session 8, and this will conclude the Accreditation Huddle series. If you would like to view previous sessions, you can access those on our PATH Huddle event website, and Carmen will post the link into chat. So for today's discussion, please feel free to unmute or type in any chat questions, answers, or tips and tricks to share with the group. Next slide. So we do have a follow-up from last week's session. So we'll review the information management standard that went into effect on May 1st. And we will cover this topic in the open discussion at the end of our huddle. So stay tuned to listen in and see what others are doing for this requirement. Next slide. So today's objectives, we will review the National Patient Safety Goals for Hospital and Critical Access Hospital Accreditation and list at least one element of performance or EPs for each goal. We will also share strategies and discuss high-level overview of the standards with updates. So for this year, the Joint Commission manual lists some major changes with the elements of performance in some of the categories. So some of the topics move to the provision of care and the infection control chapters. Also during today's huddle, we will review a few of the Joint Commission's frequently asked questions. Next slide. So a little background of the National Patient Safety Goals. They went into effect January 1st of 2003. And over the years, they've had revisions, additions, and updates. So Joint Commission makes revisions based off of information they receive from sentinel events from organizations or what they see in the field. So this is a list of the 2021 safety goals with the interventions. And this is an actual screenshot from the Joint Commission quality report on the website that's publicly available. So each accredited hospital will have one of these. So we have the quality check link that Carmen will post into chat if you want to review yours. So the key takeaways from this slide is to know that the National Patient Safety Goals, they're part of your Joint Commission survey, and they are the expectations developed by the Joint Commission to help prevent medical errors and patient harm. So there are 7 goals listed. So for survey purposes, you want to have all your supporting documentation for each goal available for the surveyor. You want to keep your policies and procedures updated to reflect the changes of the goals, since the goals are revised every year. You'll also want to have a plan to meet with your team every year to review and update your policies to reflect the Joint Commission changes. And it's also a good idea to have a written plan with strategies that show improvements. So as we go through each of the goals, please share your strategies with us. We all would like to hear from you. And I'd also like to point out that the Joint Commission's website has a lot of resources and recommendations along with the changes to the 2021 Hospital National Patient Safety Goals, and Carmen will post that link into chat. So it's a good idea to stay tuned to the Sentinel Events Alert and the quick safety newsletters provided by the Joint Commission, and we have another link for that as well. The Joint Commission also has the Perspectives newsletters that you can subscribe to for a fee. And know that keeping up to date with the Joint Commission publications and recommendations will help guide you in designing or redesigning your policies and processes, and it will keep you updated with the latest information throughout the year. Next slide. The first goal we will discuss is improve the accuracy of patient identification by using 2 patient identifiers when providing care, treatment, and services. Note that there are major changes to the EPs, including moving the eliminating transfusion errors to the provision of care chapter. So according to the Joint Commission, acceptable patient identifiers may be the individual's name, an assigned identification number, telephone number, or other person-specific identifier like the date of birth. Next slide. We would like to hear from you all. If you would please use chat to name 2 Joint Commission acceptable patient identifiers that you use in your facility. So if you will just type in what you guys use. And while we're waiting for the chat answers, I have a Joint Commission frequently asked question. Is the patient room number an identifier? A Joint Commission notes that the use of a room number would not be considered an example of a unique patient identifier. So anything in chat? Looks like name, date of birth.
Yes, that's what I was going to say. Very, very consistent.
Yeah, perfect. Yep, those are definitely 2 acceptable identifiers. So other examples of a patient identifier mentioned in the Joint Commission was barcoding, as long as it includes 2 or more of the person-specific identifiers. So this goal also states to use at least 2 patient identifiers when administering medication, blood or blood components, when collecting blood samples and other specimens for clinical testing, and when providing treatments or procedures. So the key takeaway from this slide is have a written documentation of your plan and keep processes the same throughout the facility. So you can even use this goal as a PI project to show improvements over time. So you could do a random sample by using the secret shopper observation method. So that's where the staff, they're not aware that they're being observed. And then you could track the data and look for improvements and adjust interventions as needed, such as increased staff education, put up posters, hand washing. So next slide. So the next goal, improve the effectiveness of communication among caregivers by timely reporting critical results of tests. So for this standard, you would want to have written policies for managing the critical results. So in your policies, you might want to define what is considered a critical result. You would also want to list who reports the critical results and to whom. And you would also want to include the acceptable length of time between receiving the critical results and reporting the critical results. And in your documentation, you might want to track and monitor critical values and include timestamps, and also include any interventions and processes for improvement. So if you have strategies for this goal that you're doing in this facility, please post. Let us know what you're doing for this goal. So for survey purposes, the surveyors might want to see the tracking log of critical results and with timestamps and the progress towards improvement. So if you have any strategies for this goal, just go ahead and put them in chat, and we'll be monitoring that for any answers. Next slide. Improve the safety of using medications. First, by labeling medications. So this situation pertains to when you're using medications or solutions from a multi-dose vial or container, especially if you're not immediately going to give it to the patient. So for example, setting up for a surgery or procedure. And know that the labels should include a medication or solution name, the strength, amount or volume, expiration date when not used within 24 hours, and in some situations, you might even have to put the expiration time. So the next DP is reducing harm from anticoagulation therapy. So this is a complex patient safety goal due to the nature of the medication and potential for harm. So I recommend going line by line in the manual just to stay compliant. So the key takeaways from this is, in your written documentation, you want to use approved protocols and evidence-based guidelines for medication selection and dosing, the drug-to-drug and drug-food interactions, reversal management of each anticoagulant, because they all can be different, and management of bleeding events, and perioperative management. So in perioperative management, you want to include when to stop and restart anticoagulants. And this is to prevent any adverse drug events and outcomes, and be sure to measure and document the effectiveness of your actions. So for instance, stopping an anticoagulant before surgery or procedure to prevent bleeding, and then also monitoring the estimated blood loss for those patients. So for anticoagulants in your policy, you'll want to address laboratory testing, how often to monitor, and the therapeutic adjustment guidelines. It's also important to address patient and family or caregiver education, and in that you want to include the importance of follow-up appointments and laboratory testing, the potential drug-to-drug and drug-to-food interactions, and any other potential for adverse drug reactions such as increased bleeding. So a strategy for improvement for some anticoagulant therapy, you could set a goal and track the time and therapeutic range, or the TTR, and this is for each patient that's on an anticoagulant, and work towards improving that goal. So feel free to list any strategies that you might be using for anticoagulant therapy, and if you use that time and therapeutic range, or the TTR, it would be great to know. So the next EP is reconciling medication information. So for this goal, Joint Commission added the types of medication information to be collected, and that includes the medication name, the dose, the frequency, the route, and the purpose. So you would include that information in your written documentation, along with the process of comparing the medication information the patient brought to the hospital with the medications ordered for the patient by the hospital. And you'd want to reconcile and resolve any discrepancies. So doing that improves medication safety by addressing any duplications or omissions, and then the need for the patient to continue the current medications. So for improvement tracking, you could run a report in your EHR that tracks the medication reconciliation process for each patient, and then document improvements and interventions. So out of curiosity, do any of you run the medication reconciliation report? To get that information out of your EHR, you can just put that in chat. As we're waiting for answers, we'll go ahead and go to the next slide. Reduce patient harm associated with clinical alarm systems by improving the safety of clinical alarm systems. So we would like to know, what are some alarms in your areas that you guys have, and which ones do you consider a high priority? So we can just put that into chat. Mine was always, when I worked on the floors in an ICU, it would be the heart monitors. Every time they'd go off, everybody would to look to see what was going on there.
And Jimmy, we do, kind of going back to medication review, have a question in iChat from Natasha asking if there is a report in ICARE that can be run to see if a medication review was completed.
Yeah, does any of our participants know that answer? That would be like marked as reviewed, like you reviewed the medications and started that reconciliation process. So go ahead and put in chat or come off mute if you know that answer. And we can follow up on that as well, Natasha. So with the alarm systems goal in your written policy, make sure that alarm system safety is a priority and identify the most important alarm signals to manage based on the following: input from the medical staff and clinical departments, risk to the patient if the alarm is not attended to or if it malfunctions, and any potential for harm. For example, could this cause an injury such as a burn? Also in your policy, you would want to include guidelines in regards to setting alarm parameters. So Joint Commission has a resource they recommend for additional information and best practices on alarm safety from the Association for the Advancement of Medical Instrumentation, and Carmen will post that link in the chat. So in your improvement documentation, you want to educate the staff about the purpose and proper operation of alarm system for which they are responsible. So anything in chat, Carmen?
Yes, we did have a response back from Heather Black on the report, and she said the only way would be to put in an IPL so that you can run a report for the specific IPL.
Okay, great. Thank you, Heather. Okay, Jonathan, next slide. Reduce the risk of healthcare associated infections by meeting hand hygiene guidelines. So this overlaps with the infection control standard, and there's been some major changes this year. Some of the EPs moved to the infection prevention and control or the performance improvement chapter. So for this goal in your written documentation, you want to follow either the CDC or the World Health Organization hand hygiene guidelines. And in your improvement plan, you want to establish a baseline and set a goal to improve over the past performances. So some strategies would be staff education and monitoring and tracking improvements by using, again, the secret shopper method to observe hand hygiene practices of staff before, during, and after patient care. So if the goal is not met, then you might have to redesign your plan and interventions. And if the goal is met, it should be adjusted to foster a higher level of compliance. So we have another frequently asked questions about hand hygiene monitoring during a survey. The Joint Commission's comment is, any observation by surveyors of individual failure to perform hand hygiene in the process of direct patient care will be cited as a deficiency, resulting in a requirement for improvement. So Joint Commission references a document in their manual called Measuring Hand Hygiene Adherence, Overcoming the Challenges, and Carmen will post that link in the chat too. Just out of curiosity, how many of you guys use that secret shopper method for observation? You can just raise your hand or put in chat. Go ahead and go to the next slide. So this goal reads, the organization identifies safety risk inherent in its patient population by identifying individuals at risk for suicide. So this is another complex goal, so I'll cover the highlights, but as always, refer to the manual for the details. And so in your documentation, you would want in your documentation include what your facility is implementing to prevent the risk of suicide for high-risk patients. And you'd want to include one-on-one monitoring, removing objects that pose a risk for self-harm, assessing objects brought into a room by visitors. And some strategies are to develop a checklist to help staff remember which equipment should be removed in the high-risk patient environment. And you would want to screen all patients who are being evaluated or treated for behavioral health conditions with a validated suicide risk assessment tool. So the key takeaway is that the Joint Commission requires using a validated screening tool for suicidal ideation starting at the age of 12. So some of those tools that you can use is, one of them is the Columbia Suicide Severity Rating Scale. Others are the PHQ-9. It has an adult and a teen version that asks about suicidal ideations. And another is the ASQ, that is the youth version. So your written documentation should also contain follow-up care at discharge for patients identified as at risk for suicide. And as always, monitor the implementation and effectiveness of policies and procedures for screening, assessment, and management of patients at risk for suicide. So Joint Commission has a section on compliance with suicide recommendations that can help you with your written documentation and plans. And Carmen will post that link into chat. Lots of links today, lots of resources for these national patient safety goals. So next slide. So this is our last goal. It's the universal protocol for preventing wrong site, wrong procedure, and wrong person surgery. So the universal protocol applies to all surgical and non-surgical invasive procedures. So to address this in your written plan, you'd want to include the following: conducting a pre-procedural verification process, and you want to indicate when and where this should happen. You would want to mark the procedure site and indicate when, where, and by whom. And lastly, performing a timeout. I didn't know this until I was researching this, the timeout, but there's actually a National Timeout Day, and that's on June 9th. It already passed, but there'll be one coming up next year. So that is a good time to take the opportunity to reevaluate your timeout processes and educate the staff or celebrate successes. So one strategy for this goal is to use a surgical safety checklist. And templates can be built in the EHR to document all of the parameters. And you can also set reminders and alerts for staff. So the World Health Organization has a checklist available, and there are others out there. The Association of Operating Room Nurses has one as well. So to show improvements and prevention strategies, you could run reports or perform chart audits for completion of the surgery checklist or the pre-procedural verification process and the timeouts. So other strategies are getting everybody involved with the communication, including the schedulers, a surgical team, and the patient and the family. So Joint Commission has a web-based application to help with this goal. It's called the Safe Surgery Targeted Solutions. So this helps promote safety with the wrong site, wrong procedure, and wrong surgery. So I didn't know if there were any of you out there that are using this tool or have heard about it. So if you have, and you could just provide a little bit of feedback, your success with it, that type of thing. But according to Joint Commission, the most common issues with the universal protocol involve errors during scheduling, errors with the verification and documentation process, staff being distracted or rushing, inconsistent site marking, punitive safety culture, and timeout process errors. So the use of this tool, the Safe Surgery Targeted Solution tool, is supposed to help prevent those errors. So it might be worth checking out. Another strategy that Joint Commission recommends is to do a walkthrough to observe and assess your facility's processes that could contribute to the wrong site, wrong procedure, or wrong patient surgeries. So again, that secret shopper method. So the key takeaways: you want to have written processes and policies that are up to date with the Joint Commission standards and are up to date with any evidence-based guidelines you are following. So next slide. So like I said, we had a lot of links today. So we've listed those here on the resource page. And the presentation, this presentation will be updated with those links. So you want to check back with that huddle reminder, that the email that was sent out Tuesday, and it should have these links on here if you missed any in today's chat. Next slide. Okay, now is the time for any open discussion. I know I talked pretty fast, but if you have any questions on the National Patient Safety Goals or want to share any strategies that your facilities are using, now is the time. We have our subject matter experts here ready. You can either come off mute or put them in chat. Do we have any brave souls out there? One question that I had is the timeout template. Is that something that's available for you to use in your EHR? Is it embedded in your EHR, or is it something that you do on paper? Mostly for like surgery staff, but the quality leaders might have answers to this. Didn't know if that was something that you were using. Paper. Jennifer Moore says, thank you, Jennifer. And then that can be, you know, scanned into your system, and then you can do chart audits on it. So that could be your strategy for your improvements, to kind of see how many are being done on patients. What about, do any of you use the time in the therapeutic range for measuring the anticoagulant safety goals? And I know Natasha said, is there something that could be built in your EHR, or do you think staff prefer paper? Anything time you can, you know, get it in your EHR and you can pull it out in a report, like a structural field where you can have those reports that are really readily available, is a big help. So is that something that can be built in the EHRs? Does anybody know that? Make a template. Everybody's quiet. We do have a frequently asked questions, if you have, that you can send to the standards interpretation group at Joint Commission, and I'll go ahead and I'll put that in the chat too. Yep, did somebody come off mute?
Yeah, this is Jennifer. I think Heather answered it. You can put it in EHR. You just have to make sure it's completed correctly.
Yeah.
And also, I think a lot of our OR, at least at Gallup, it's still, the documentation still in paper format for a lot of our OR services.
Yeah, and then you're scanning it in, and then you're still able to access that in the patient's chart, correct?
Correct.
Yeah, yeah. And that's one way to do it for that safety goal too, is as long as you have that information in there and it can be pulled out, you know, a manual chart audit, and you can keep track of your improvements. And Natasha says it's difficult to transfer OR documentation into the EHR. Yeah. Or build into it. Yeah, building the templates. It's time consuming. It is. Sometimes it's easier to get the pen and paper out and mark checklists. All right, do we have any other comments or questions? If not, we're going to go ahead and move on to the next slide. And this is our hot topic item, the new interoperability rule, and Natasha Green will lead this discussion.
Thanks, Jimmy.
Yep.
And we do have Dr. Postal who's with us. So Dr. Postal, if I misspeak on anything, please feel free to chime in or add anything if I miss anything. But during last week's huddle session, Nancy McDonald gave an excellent overview on the new interoperability rule, and there were some questions about it. But just to give a little background before we go into some of the answers that we were able to find, the interoperability rule is that the hospital meets requirements for electronic exchange of patient health information. So below here we have a summary of the 5 elements of performance. The first one is that it has fully operational notification capacity. It sends notifications that include patients' names, treating practitioner, and sending institution's name. It sends notifications at the time of the patient's ED registration or inpatient admission, sends notifications either immediately prior to or at the time of the patient's discharge or transfer from the hospital's emergency department or inpatient services, and confirms that its electronic medical record system sends the notification to post-acute care services providers and suppliers who need to receive notification of the patient's status for treatment, care coordination, or quality improvement purposes. Next slide, please. And these did go into effect May 1st of this year. So to help prepare for the new standard that came into place, the IHS team found a way to support that new COP in the new standard, and they created a recommended plan of action to be taken. And so to do that, they created and used 4 purpose-built ICARE panels at each of the IHS hospitals. They include an inpatient admit notification, inpatient discharge notifications, ED current admit notifications, and ED recent discharge notifications. Each of the panels will be configured to display the required elements to meet the standards, and the information will update daily in an automated fashion and will also update with the current information on demand via the repopulate button. And the panels are created once and then shared with the providers, nurse care managers, and other team members. Communication regarding the new panels was sent to the area office directors, the NCCMO, NCC CEO, Office of Quality, NCI, and other key stakeholders on May 15th of 2021. If you're looking for that notification or that memo, the subject heading was ADT, Event Notifications Requirement for Hospitals Using the Resource and Patient Management System, RPMS, Electronic Health Record, EHR. And then, of course, the facilities were provided with outreach and training for hospitals, informatics, and other stakeholders to assist with creating and using the panels. And that education and training was provided on June 16th and June 28th. And next slide, we will go ahead and show you how to access that training. So if you're looking for it and you're wondering, how do I get access to this? How do I make sure my staff members know how to use these panels? We'll go over that shortly. Next slide, please. So to access the new training on the ICARE panels, you'll want to go to the link that you can find here in the PowerPoint slides. And as Jimmy had mentioned before, the link was sent in the reminder email that you should have gotten yesterday. And that link will be updated with the current PowerPoint and the current slides, so you'll have that. But we'll also go ahead and copy that link into chat now. So if you just give me a second, I'll grab that and paste it in. You'll want to select the ICARE training from the RPMS select box with the dates of 6/15 through 6/29. And once you do that and hit search, the training will display. And once you do that, you're able to just click on the training and you'll be able to review the training that occurred on either of those dates. So I don't know, Dr. Postal, I saw you put something into chat, but did you have anything that you'd like to add regarding the ICARE panels or how to meet that standard that you wanted to add to the discussion?
Thank you, Natasha, and you did a great job presenting. The one thing to note is that I just spoke with CMS prior to it becoming, a rule in May. It doesn't go into effect until July 1st. So the rule went into effect, but the where they're going to start looking at the that you're adhering to it, the standard. In other words, CMS final rule went into effect May 1st, but the standard issued by the Joint Commission does not take effect until July 1st, 2021. One thing that we noted again is it's addressing patient event notifications, so admission, discharges, or transfers. And one thing we can do, so we're showing that this is the best that we can do with our system, and that's care provider whose patients are in RPMS. So it would not send notification out to an external provider or an external provider to the IHS facility that how you have your CCD report to inform, if care provided outside externally. So this is what we have addressed as our workaround. And we did mention that to the CMS team who is addressing this part of the rule. Over. Thank you.
Thank you so much. Are there any questions about this new rule or the action plan? All right. Well, I hope that this was helpful, and I'm thank you all for getting this information back to us in a timely manner. This was our last current huddle series for the accreditation and certification and PCMH team. So we appreciate you guys getting that back to us. So thank you very much.
Thank you. And if there's any questions, you're more than welcome to reach out to me and I can follow up. Thank you.
All right, Jimmy, I'll go ahead and hand it back over to you.
Great. Thank you so much, Natasha and Dr. Postal, for that. I know that was, we've been waiting on some information on how to handle that new rule. So we appreciate all that input. So go ahead and go to the next slide, Jonathan. So if there's not any other conversation on the National Patient Safety Goals, we can go ahead and talk. We have a few more minutes left here. If you guys you have any questions or concerns, or you want to share any of your strategies, anything that you do with the National Patient Safety Goals, now's the time. And Natasha says she's excited for the upcoming Cultural Safety Huddle series. Yes, so our next, this was the last session for the accreditation certification huddles, but we are going to start back up again in September for our next huddle series, and it's going to be leading a culture of safety. Some more information coming soon. Just know that you will need to re-register for that, and we'll be sending those links out, so we don't want you to miss any of those. So yeah, we're excited about that too, Natasha. Okay, go ahead and go to the next slide. So this is a thank you for joining today's huddle, and please, before you sign out, we want you to fill out our questionnaire. This is a post-event assessment. This is to get your feedback so we can improve our events. Carmen just posted that assessment link in chat. If you would please fill that out before you leave the room, and we will stay on a little while longer if you have any questions or any comments. Otherwise, have a wonderful rest of your week.